But I'm going to move on straight away onto the next lecture, which is Dr. Tim Yusuf, who's going to talk about how you characterize these focal lesions and how you perform and how you interpret the results. So, Tim, over to you now.
Thank you. Thank you for the welcome. So I'll be speaking about characterization of the focal liver lesion with contrast enhanced ultrasound, the examination, and how to interpret the results. And I'll recap some of what we've heard a little bit already as well. So where Professor Sidhu has finished, I'll start off. So the how to perform part of it, I think we have to split into the big questions. We know that we have to answer the how, but also the what, why, who, where, and when. And the how to interpret results is not just about getting information. We need to actually know what to do with it. And that's where the characterization and scoring systems come in. And I'll go through each one of those in turn. So just very briefly covering a bit more about it. So the idea of contrast enhanced ultrasound, as we've heard, has been in existence for a very long time and started with our cardiology colleagues in the 60s. So it's not really a new technology, but we need to take it forward, and it's been moving forward progressively over time. And if you just type into PubMed, that really shows you quite how much data there is out there about it. Almost 60,000 studies. It really is becoming a part of established clinical practice worldwide. And we see that with the description of what's happening in China with their use of it there. In the early days, it was used as a relatively blunt tool by comparison to now, where we just wanted to analyze whether or not a portal vein was patent prior to a liver transplantation. And we used the contrast enhanced ultrasound as merely an agent to boost Doppler signal. Obviously, it moves on, and then with industry progression as well, there's a need to think about what else can we do, and that's where the characterization of liver lesions comes in. And again, that was early phases, but then refined with industry developments. And in addition to the development of this, there's also been development on the aspects of the microbubbles themselves, that transpulmonary stability. But we need to know first and foremost when we start something, is it the right thing to do? Well, we'll come on to that, but it's certainly safe. This was the original study that was showing 23,000 patients with a very minor adverse reaction rate. And as we've heard now, that 0.0086% has actually reduced. It's actually even safer in larger scale studies than we knew before. And that's much higher, much lower than the adverse reaction rate you see with CT or MR. But yet we don't bat an eyelid about the idea of giving CT or MR contrast to patients. So therefore, why should we think about it so much with ultrasound contrast? The truth is, it's just a matter of exposure and learning and development with it, and then we'll see quite how safe it is. Well, why contrast enhanced ultrasound? Well, also, as we heard, it's a dynamic modality. This is a method where you can actually see what's happening. We might think we know how things are going to turn out based on what we see, but it may be entirely different. As you've heard, you're seeing a movie rather than watching a snapshot, a poster, a period of time that someone gives you at various intervals. So you know exactly it's maybe different at the start and therefore it may be different at the finish. You can predict it because the phases that we talk about in the liver, they are in fact overlapping. They're not discrete entities. You have an arterial phase, a portal venous phase, and a late phase, but it all exists over a spectrum. There's not an abrupt start and finish. But also, it's not just us. For in the UK, it's our highest governing body for clinical excellence, which is nice, which demonstrates that sonoview microbubbles are very useful for characterizing focal liver lesions. And this was on the back of a large amount of data that's produced, but also a cost analysis, which I'll come on to in a minute. So where is it useful? Well, the inconclusive lesions, and as was mentioned earlier, really and truly, unless you see a cyst or a typical hemangioma in the liver, you're essentially talking about a lesion that's inconclusive and you cannot characterize it further confidently in that session. So therefore, although the NICE recommendations say it's for an inconclusive incidentally discovered focal liver lesion or detecting metastasis in patients with no malignancy, if CT is not appropriate, and detecting, monitoring for focal liver lesions in cirrhosis if MRI is not appropriate. However, it also says, or in whom an unenhanced ultrasound is unsatisfactory or contrast is needed for further diagnosis. So, of course, in that situation, when you have scanned them first, you are seeing a lesion. To be able to characterize it, you've got to be very brave on B mode ultrasound on its own. So adding contrast adds that confidence to your ability to diagnose and may prevent from the next steps the patient may have to undergo. Also bear in mind that does mean it is viable as a second line agent as well for those indeterminate cases. And that's the clinical side of it. But what you'll have to do is take this to your managers and be able to convince them of that the use of contrast enhanced ultrasound. And this is a part where money speaks. So on the left, we've got a couple of papers, including our paper, which looked at pediatric contrast enhanced ultrasound and showed that it demonstrated a significant saving over both CT and MR. And that was particularly true in cases of trauma, where you had repeated CT imaging. Also, there's this paper from Italy, which looked at benign focal liver lesions and activity-based cost analysis. And I draw your attention to the fact it mentions pseudo lesions, the focal fatty infiltrations, the focal fatty sparings. This represented, again, a significant cost saving. And these two papers on the right, I'll just take you through in slightly more detail. So this is one from a number of centres in the UK, which looked at a hypothetical world about using contrast enhanced ultrasound with and without it, and what it was like. So in a base case, a simple base case, looking at their analysis of focal liver lesions, they said if we use it in just 5% of cases to analyse focal liver lesions, that's £250,000 per year the NHS saves. That is a huge volume. When you think to yourself that this £250,000 is what buys you a new piece of equipment, this £250,000 is then rolling over to give you new staffing. This is a huge amount for a system that is under strain. But it doesn't end there. The analysis goes further. And what you can see is that there's scenario analysis that looked at what if we used contrast enhanced ultrasound as the first line investigation, and we accounted only for 50% of cases of focal liver lesions. And this is very much not unrealistic. This is a very, very possible situation. That's 2.25 million per year. And bear in mind, volumes of activity is going up and up in an exponential level. So that volume will increase year on year. If we look towards using in 90%, that is £4 million per year. It's a huge volume. You look further and you say, well, what about somewhere in the midline? 33%, 1.5 million. And then there's a few other scenarios, and there's the quite unthinkable scenario of using CT and MRI without contrast. Really, if I'm honest, you're talking about quite non-diagnostic modalities for characterizing liver lesions, if that's the case. But even that represents a cost saving. And that's also what this health technology assessment from Westwood et al. Showed. It based contrast enhanced ultrasound at approximately £65 and showed that there was a significant saving to be had for cirrhosis screening. And that was the first one they mentioned, because MRI costs £1,063 more. And it's simply impractical. You cannot have every patient with potential oncogenic virus or cirrhosis being screened with MRI. There's no availability. The time is too long. So it does represent value. It's also as effective as contrast-enhanced CT for identifying colorectal liver mets. Furthermore, in the incidental focal liver lesion, it's where contrast-enhanced ultrasound is not just equal, but it really shines. It is a cheaper modality and represents greater quality-adjusted life years. And that is the reason for the NICE recommendations. And let's put that into a practicality. So you discover you're running your normal ultrasound lists and scanning, and you discover an incidental focal liver lesion. What is the pathway for that patient? Well, they then generate a cancer referral because obviously it needs to be characterized, and the concern is malignancy. Rightly so. They then get seen within clinic within 2 weeks. They then have a diagnostic. It might be a CT, it might be an MRI, it might be an ultrasound, it might be a contrast enhanced ultrasound. They're then seen in clinic or go to the MDT, but they end up in clinic. One a slightly longer route than the other, but they end up in clinic. They're then told they're either benign or malignant. And if they're benign, they're usually discharged. Malignancy follows its own pathway, as you know. Compare that to contrast enhanced ultrasound. In the room, at the time of discovery, you take that 5 minutes to put the cannula in and do the examination. You look back and you report the examination, and then what happens then is they're either discharged or it's a malignant lesion and it's a cancer referral. What's the difference? 2 weeks. 2 weeks is what our standards are. That's 2 weeks of anxiety for the patient, 2 weeks of anxiety for the operator, potentially thinking, have you done something right or wrong? 2 weeks of cost, recurrent visits. It's a lot for a patient to undergo. Compare that to 10 minutes in the room where you have a diagnosis. And what I emphasize from this slide, you are looking for the benign lesion. Yes, the patients might undergo CT if they have a cancer. Yes, they may undergo CT if they have a metastatic disease. But if they are benign, you are saving them all of that trouble, all of that anxiety, and you're preventing them from having unnecessary examinations. Your hospital will thank you. So who can have it? Well, the truth is almost anybody. We know that it's been shown to be safe in pediatric patients from our study, from the EFSM statements, but also it's been increasingly recognized that the contrast ultrasound agent does not cross the placenta and therefore is thought to be safe in pregnancy. And the larger scale studies have showed it's safe in almost everybody else. The patients that we need to be aware of who will benefit most from contrast enhanced ultrasound are those that are radiosensitive, the pediatric patients, again, as their pediatric traumas. Those patients with renal failure, there's no nephro or hepatotoxicity. You do not need to check bloods beforehand. And in my hospital, certainly that's a problem. Often we get patients without EGFRs being sent to CT. So it's something that certainly saves you in those occasions. I don't know if anyone has been into an MRI scanner or not, but it's certainly not the most pleasant experience in the world. It's very small, claustrophobic, loud. So you can understand how a patient wouldn't like it. And you are not there for a couple of minutes. You are there for potentially an hour or more. The patients who are immobile, let's not forget, there are patients who come into A&E who are too sick to come to the department. There are patients who are too sick to move from ITU. There's an impracticality about bringing a whole load of things down. Potentially, if you're going to an MRI scan and maybe you've got magnetic parts and metallic parts that you can't take in there. There are other parts of the body you can't examine with anything else, and there are also the second line investigations for focal lesions. So the next question that we raised here is how? How do we do this? Well, what you need first of all is your optimized B mode and color Doppler study. That's critical because you need to be able to see what you're looking at. So you can do this as somewhat of a screening examination with late phase sweeps, which I'll come on to mention later, but it's best when you're targeting a specific area. Bear in mind that you do need peripheral cannulation. Usually this is quite helpful to have a second person in the room. At a great push, it can be done single-handedly, but certainly I would suggest to sit an extra person in the room to both cannulate and inject for you. Usually best on the opposite side to the side that you're scanning. You then also need to perform a check flush, make sure that your cannula is in the right place. Although you haven't got the same concerns about contrast extravasation like you do with iodinated contrast, you don't want to end up with very little in the system and then a poor image based on that. The sonoview is injected after being reconstituted, and you can see from that image there, the pack comes as a vial with powder, which you then put into the spike and inject a pre-filled saline syringe. Once it's agitated, shaken up and down enough, and all the white stuff has disappeared from the bottom, it's then suitable to be drawn back up and injected in the appropriate dose. As I mentioned earlier, we need a video acquisition, and particularly when we talk about the liver, we need to scan for longer, 5 to 6 minutes usually. But take the video acquisitions because this is your opportunity to go back and look at these examinations. You don't need to just try and interpret it there and then. You certainly wouldn't think about sitting in an MRI scan and interpreting the sequence as it comes through. So take your time, write a report that's of quality that you want to give out rather than trying to rush one. And also, I must say that you need an anaphylaxis kit. So I would be practicing this in a place where certainly you have an appropriate facility for anaphylaxis, because there is, no matter how small the risk, there is a risk present. So once you've done your optimized B mode, taking into account that you need to be in the appropriate plane of the lesion. So the lesion may move up and down with respiration. It's a slightly different practice, keeping your arm relatively still as opposed to constant movement of ultrasound. You also need to make sure you're in a plane that avoids calcification or gas in front of the lesion to stop it, to prevent your visualization. You then want to enter ideally a split screen mode. Some people use an overlay mode. What this allows you to do, though, is to keep the B mode of the lesion in view. And that way, you don't misjudge where you are coming off the lesion. You can confidently be in the plane of it, and that's why it's quite useful to make sure when you are in a plane of the lesion that it's moving up and down rather than in and out of your field of view. You then inject the desired volume. We are finding more and more that 2.4 mils in the liver is perfectly fine, as opposed to the 4.8 that was originally found because of the development of newer technology within ultrasound equipment. But we're also finding that you can use lower doses elsewhere in the body. But bear in mind, once you've injected, as has been said before, you can scan whatever organ you want. You may look at the liver, go away for a bit, look at the kidney, go away and look at the spleen, go back and look at the liver. It systemically circulates. You then, once you've injected, you commence your timer from the moment of injection, and you need to keep a video for that first 60 seconds. That's your moment where you can tell whether your washout is happening early or late, which I'll come on to later. Subsequent to this 60 seconds, you want to be taking intermittent freezes and still images or short video clips of just a couple seconds up to 5 minutes. And that's to prevent artificial washout of these lesions and bubble destruction. It's important when you first start your contrast image that your gain is at an appropriate level. The reason for this is you want only the very brightest echoes to show through pre-contrast administration. If the gain is too bright, you'll be eradicating the top end of the histogram. You'll be creating such a blur of intensity that it'll be hard to evaluate the detail of the structure. Similarly, if your gain is too low, you're only getting the very top level echoes coming through, and that may mean you miss fine details. You do need to try and make sure that once you're in the contrast mode, you don't switch back to a Doppler, you don't switch to elastography, or don't switch off the contrast mode because you risk bubble disruption or disturbing your timing. You also need to think about what transducer you're using. For the liver, it's almost inevitably a curvilinear 3 to 5 megahertz transducer. That's the frequency that the bubbles resonate best at. You also need to think about having a high frame rate to make sure that you're able to capture this in real time. When we talk about capturing the images as well and deciding what we want, think about what your aim is. So in the case of liver, we're talking more and more about LIRADs created by the American College of Radiologists. And we want to be talking in the same language, particularly in terms of the risk of HCC, which is what this was created for. And to do that, we need to make sure we fit the criteria. And that's what I've described earlier. The 60-second videos with 4 to 5 minutes images time total and late phase sweeps. It's also important to do the video acquisition because it might allow you to do time intensity curves. So many of the machines now have this built in, and certainly there is software like ViewBox, which allows you to map the points on a pre-acquired video image and determine whether or not your lesion is hypo, ISO enhancing in a quantifiable method. And whilst this isn't in day-to-day practice as yet, it certainly is something that is used for research. So that's the how. That's the how to do the contrast ultrasound, including the why and the where and the who. But now, after all that data, we need to figure out what we do with it. Is it useful now that we've acquired our images? Well, we put it together, put it all in a pot, and we create this black box, which allows us to come out with some idea of what's going on. And that's where the FSM guidelines come in. I've put both the hepatic and the non-hepatic guidelines in there because they are excellent. They are freely downloadable. They very much can give you a good starter for contrast enhanced ultrasound of what you're looking at. To summarize, though, we need to think about what the liver lesion looks like, and you often work this back to front. So that's one of the reasons why it's quite useful to have the video clip and then subsequently look back at it and create your report. The first thing you need to know on a very basic level is the lesion enhancing. If the answer is no, it means there's no vascularity within it. The contrast enhanced ultrasound, sonoView is a purely intravascular agent. It's a blood pool agent, which means that it doesn't get excreted in the kidneys, it doesn't get excreted in the biliary tree. It's purely stays within the bloodstream. So if there's no contrast enhancement within a lesion, that means there is no vascularity within the lesion. It's the only two things that happens with the cysts and abscesses. Abscesses may have a rim enhancement, or they may have a sort of honeycomb septation, but there's no solid component enhancement of it. If it does enhance, you need to think about what the arterial and the venous phase looks like. In the arterial phase, is it rim hypovascular? Is it peripheral nodular, or does it have that central artery? And where does it fill from? Is it central or is it peripheral? But actually, it's often easier to look at the late phase first and look at the washout. By washout, we mean, is it less enhancing than the adjacent parenchyma? If the answer is yes, you think about HCCs, cholangiocarcinomas, metastasis. And if the answer is no, think about adenomas, hemangiomas, FNHs. Now, this is a rule of thumb. There is some overlap, but as a general rule of thumb, it works very well. And what you may have noticed, the answer to yes washout suggests malignancy. The answer to no washout suggests a benign lesion. And that's why it's useful to look back and work backwards from the venous phase back to the arterial phase. The world changes when we talk about the cirrhotic liver and the oncogenic lesions. These are, when you see an arterially enhancing lesion within a cirrhotic liver, you must be thinking about malignancy and dysplastic nodules or HCC. So I'll take you now through each one of the lesions. So here's focal fat. Focal fat, I've listed as focal fat rather than sparing or infiltration, and they fall under this category of pseudo lesions. Ultimately, they are normal liver, just differential degree of fat quantification within it. Now, that's because of things like the third inflows of pericholecystic veins or the falciform veins, etc., which means that the fat deposits unevenly in the liver. However, although they have often geographical appearance, they can look quite typical, adjacent to the falciform ligament, adjacent to the gallbladder, anterior to the portal vein. They can look nodular and they can be difficult to determine. But they are ultimately normal liver, so they enhance the same as the background liver in all phases. And here's the slide I added just now, actually, because this was an interesting case that I just scanned. Here's a patient who it's very difficult to see through such an attenuating liver. But again, the world is changing. These are the cases where it would have been said, send to CT, send to MRI, because we can't exclude something. Well, now you've got much better penetration. You've got an ability to be able to see things much deeper than you ever used to. And here, when you put on these deep abdominal probes, you can appreciate, and I hope you can see the mouse, so you can see a lesion next to the gallbladder fossa, but it does look nodular. So is this now an HCC? Well, no, because it enhances normally in the arterial phase, symmetrical to the background liver, actually has vessels running through it, and it doesn't wash out in the late phase. So this is focal fatty sparing, but you're able to prevent a CT or MR for that patient for that reason. Cysts, these are very common. They're the commonest incidentally discovered focal liver lesion. And we dismiss them because normally they are simple cysts. They're clearly anechoic. They've got no Doppler signal. They've got through transmission. And very rarely do you need to do a contrast enhanced ultrasound. But on the odd occasion, there may be debris within it. It may simulate a lesion. It may be completely filled. But the only way to be sure is then by giving ultrasound contrast, ensuring that there's no vascularity within the lesion. But this is a rare occurrence. Hemangiomas. These lesions are benign lesions. They're thought to be as common as 1 in 5 females, almost always incidentally discovered. They're the most common solid focal liver lesion. They can either have a typical or atypical appearance by description. On BMO, the typical ones do not need contrast enhanced ultrasound. They are small, subcapsular, adjacent to the hepatic veins. very hyperechoic, and they may have a through transmission as well. And even with the development of microvascular imaging, you may see some peripheral Doppler signal on the outside of some of them, but it's less likely. When you see these sorts of lesions, you don't need to do anything. However, as they grow larger, they may become indeterminate. It may become more heterogeneous. And I think you'd be brave on the B mode imaging to say that this is a hemangioma and the lesion that we can see in the video. But when you administer contrast enhanced ultrasound, they have a very typical appearance. They peripherally nodular fill, the gradual infilling. They may not fill completely in. There may be a central scar with it that doesn't fill. But these are pathognomonic appearances, and they show sustained enhancement in the portal phase. The other types of hemangiomas which occur are the small flash filling hemangiomas, usually less than 1.5 centimeters, that show uniform early enhancement, critically no washout again. Then the large hemangiomas we've talked about, the ones that may have a central non-filling. And the type 2 is the more typical one that we described that shows peripheral nodular enhancement, gradual infilling. Focal nodular hyperplasia is the next most common lesion. It's thought to be 1 in 8 women. It's had about a 10-to-1 female to male predominance. And this shows a typical pattern because it is ultimately normal liver in a disorganized fashion. And we've talked already about the central filling vessel, the central artery or central star, which has a spoke wheel appearance. So it becomes very arterially enhancing, this lesion, and it sustains its enhancement in the portal phase. It doesn't wash out. It either stays iso or hyper-enhancing. It may show a central scar. And there's a subtle difference there between the star of the filling vessel and the scar, which is the central fibrotic area. Now, in an MRI, the contrast is different. So it then enhances late that central fibrotic area, as opposed to contrast enhanced ultrasound, where the central scar does not enhance because it is not vascular. And here's an example. You can see a small focal lesion just in segment 6 of the liver. You can see a central filling star pattern. It's arterially hyper-enhancing, as you can see from the images on the right. It shows no washouts in the late phase. That's an FNH. Similarly, you can see another couple of examples of lesions here. You can see the MVI does show you a very vascular lesion. It shows you quite nicely that star, but you need that temporal nature to be sure that this doesn't wash out and that this isn't just a very vascular metastasis. And here's what you can see. You can see that central filling artery again, hyper enhancement. And then at 2 minutes, it's still not washed out. It's still remaining quite hyper enhancing compared to the background liver. By comparison to MRI, of course, you get your hyper enhancement in the arterial phase because the pathology is the same, but the contrast agent is different, which is why you get the central scar filling and enhancement late on MRI, but not on contrast ultrasound. The next lesion we'll move on to talk to is adenomas. These are proliferations of pleomorphic hepatocytes, but they lack the normal architecture. Now, there is a heterogeneous group, but they're linked to things that cause increased steroid production. So oral contraceptive pill, anabolic steroids, glycogen storage diseases. But these are things that we need to make sure we've got the history for beforehand. But unfortunately, adenomas are a heterogeneous group, so they behave differently. They typically show arterial hyperenhancement, and in the portal phase, they may be iso or hyperenhancing, but also they may be hypoenhancing. They may show washouts. Now, this is because of the nature of adenomas, and this excellent paper from Radiographics describes it a bit more. The 4 main subtypes are inflammatory, HNF1 alpha, and beta-catenin, as well as a mixed type. Now, the inflammatory adenomas are the ones that are more prone to bleed. The HNF1 alphas are almost exclusively an oral contraceptive pill and have been shown show the typical in and out phase loss on MRI with fat accumulation. Whilst the beta-catenin are the ones we want to look for, because 35% of these have a mutation that overlaps with HCC and therefore can be considered as potentially pre-malignant. But you cannot characterize them because, unlike the others, they have no specific dividing features. That is why, if you see a lesion that washes out, even though it may be an adenoma and it does not resolve on cessation of the oral contraceptive pill, you are likely to have to biopsy it because you need to know what type it is. So therefore, the washout rule still holds true. And here's an example. We can see two examples here, actually. You can see an arterially filling lesion in both, but what you're looking at the lesion on the bottom is you're looking at creeping vascularity, but the vascularity is different. It's from peripheral to central, as opposed to the FNH, where it's from central to peripheral. So it's not just about the enhancement, it's also looking about the type of enhancement that you get with it. So talking about the next lesion is abscesses. This is an example that's normally quite clinically obvious. The patient presents with right upper quadrant pain, sepsis, fevers. They often have a prodromal illness beforehand of diarrhea, vomiting, because abscesses often ascend from the gut. Typically in children, you talk about appendicitis or diverticulitis in adults, and may be associated portal vein thrombus. But the etiologies do vary. They are ultimately of cyst full of pus. So there's no enhancement within it. There may be septations, there may be a honeycombing, but these are spared areas. And they may show an enhancing rim of granulation tissue, but there is no solid component within it. So as you can see from the B mode, this very solid looking lesion shows no enhancement, it's just it's an abscess. That rim may wash out, but again, that's due to the inflammatory reaction as opposed to a malignancy. Moving on to talk about regenerative nodules. Now, this is quite an interesting topic because we're bridging the gap between the healthy liver and the diseased liver. In the diseased liver, things change dramatically. Regenerative nodules are part of the process of cirrhosis, and macronodular regeneration is something we see very commonly. So in this case, we can see that although we've got a small hemangioma, this hyperechoic lesion at the porta, which was shown, there's also this larger nodular looking area adjacent to the gallbladder. What this is part of normal liver still, similar to how we described focal fatty sparing infiltration. So it does iso-enhance in all phases. However, regenerative nodules do exist on a spectrum where they can become dysplastic nodules, and dysplastic nodules can vary from low grade to high grade to a fine line before it starts to become a well-defined, well-differentiated HCC to eventually a poorly differentiated HCC. And what's important about this is that you have a decreasing normal arterial supply. You have an increasing supply of unpaired or non-triadal arteries, neoangiogenesis, and a decreasing portal venous supply. That manifests with a particular enhancement characteristic, which is why there is a non-diagnostic criteria. And that's why it exists on an overlap with HCC. Now, the majority of HCCs do happen in cirrhotic patients, but there is a small percentage, approximately 5%, that occur in the non-cirrhotics. They are a heterogeneous population, though, because they are oncogenic viruses, such as hepatitis B, which are as a primary oncogenic and can result in HCC on their own. The non-diagnostic criteria is approximately 1 centimeter nodule, arterial hyperenhancement with portal venous washout, but that washout is normally late phase. So here's an example of it on CT. Here's an example on contrast enhanced ultrasound. You see it so clearly, that arterial basket pattern enhancement, but the washout is quite mild at 4.5 minutes. It's progressive, but it's mild, and that's diagnostic of HCC, and would be considered an LR5. And this is a LIRAS, which you mentioned earlier. And it really goes to show the American College of Radiologists were confident enough to issue a CEUS LIRAS alongside a CT and MR LIRAS, indicating the knowledge of its utility. And as with all these criteria, all the RAS systems, it's a 1 to 5 scoring system, where 1 is definitely benign, 5 is definitely malignant. But importantly, there's an LRM category, which means a malignancy not likely to be HCC. There's also TIV, which is tumor in vein, and it acknowledges the fact that contrast-enhanced ultrasound can detect and identify malignant portal venous thrombus by means of washout within a portal venous thrombus. The important thing to recognize is the differentiation of cholangiocarcinoma. Although also a primary hepatic tumor, it's got a very, very different management pathway. And this is because, initially, some time ago, contrast enhanced ultrasound was taken out of guidelines for recognition of HCC because it was thought there was overlap with cholangiocarcinoma, but that is clearly wrong. The enhancement pattern is very different for cholangiocarcinoma. The peripheral mass forming cholangiocarcinomas are usually either hyper enhancing with a nodular rim, but they do rapidly wash out. And they may show things like capsular retraction as well. And very much you can see adjacent biliary ducts dilated next to it, which you can appreciate as a non-enhancing ducts next to this primary tumor, which is showing quite a deep and obvious washout. The final thing I'll talk about is metastatic lesions. These are the other common lesions. They're actually thought to be as common as 25% of carcinomas at autopsy. And although multiple lesions are suggestive, we've all seen multiple hemangiomas, we've all seen multiple adenomas. They can exist that there are multiple benign lesions. The pathology varies, and as a result, the arterial phase enhancement varies. They may be rim, hypo, or hyper-enhancing. But importantly, they always wash out early, so before 60 seconds. And that's why that 60-second mark exists. HCC is late washout beyond 60 seconds. Metastasis are early washout before 60 seconds. And here's an example, where you can see that there's a lesion detected on a PET scan, quite a subtle lesion on the B mode scan, very much arterially enhancing, very much washed out within just 46 seconds. That is your diagnosis. And I talked about doing a late sweep. This is your opportunity now. You've got the lesion characterized. Sweep through the rest of the liver. Identify those micrometastases that are not able to be fused correctly on the PET, not able to be picked up on the MRI due to the slice thickness. Those lesions that can only be picked up on contrast-enhanced ultrasound. There are a couple of other papers, a couple of other uses for contrast-enhanced ultrasound apart from liver lesions I'll just mention. Vascular interrogation, I'll just revisit this paper here and demonstrate to you. The initial use was in 2000, looking at portal vein patency, but actually, you can look at it still now. You can identify if the portal vein is patent. If there's tumor in vein, you can use it to boost the signal still. You can identify recurrence at cut sites, particularly if there's been previous hepatectomy. If you want to know if you have a margin, you can identify infarction. And very much you can also look at trauma, which is one of our major uses, and avoids the need for recurrent CTs, particularly if it's single organ. You can so clearly see a laceration, but you can also very clearly pick up any pseudoaneurysm that may form. Here's another example. This is a lesion identified on CT. Quite hard to appreciate on ultrasound, can't really see anything there. Contrast enhanced ultrasound. Well, what is it? Is it a lesion causing a problem? No, it's a veno-venous shunt, which you can clearly see, and you can watch that perfusional abnormality happening in real time. And you can track along the vein, the hepatic vein into the portal vein, and be confident of what you're looking at, as opposed to subjecting this patient from a CT to an MR, then going back for a CT chest if you're wondering if it's a staging. You can evaluate it there and then in real time. And I will promise I'll finish with this one. This is an example of an endocavitary contrast-enhanced ultrasound. It's a purely intraluminal agent. So as you inject it into a cavity, it stays within the cavity unless you have a fistula. And here's where you can see a biliary arterial fistula on contrast-enhanced ultrasound, because when injected into the biliary drain, the liver parenchyma is enhancing, and that was confirmed on angiography. So I'd summarize by saying contrast-enhanced ultrasound is accurate, it's safe, it's quick, it follows guidelines, and you've got a very easy and very good cheat sheet in the FSIM guidelines and the ACR guidelines. It's also a problem-solving technique, so it is in your power to use it, and it's in your direction to use it. So I'd strongly advocate its use, and hope you've enjoyed today's talk. Thank you.
Thank you very much, Tim, for giving us a very comprehensive overview of how you look at focal liver lesions and what the most important aspects are, which is really the washout or it doesn't wash out. Thanks very much.